Good afternoon, everyone. Once again, I welcome you to the session, Transition of Care and Disclosure for Children. We're going to have for this session a key speaker in the person of Dr. Adua Komua Asare Afon. Apologies if I did anything in massacring that name. You're going to come upstairs to revive it. Please, I sincerely apologize. But we do know she's a consultant pediatrician with extensive experience in talking about transition of care and disclosure from children, what it means to transit them clinically. But beyond that, we know that when we're talking about transition, there's a lot more to this context. It's not just the clinic, it's the social environment, it's their life systems. And I'm going to depend on you, the audience, to engage us in this discussion, including discussing in depth the presentation of our key speaker. On that note, I'd like to invite her and to the podium. She would introduce herself better. Please take note of the names and the accents, and then we go on to engage. Thank you very much. Thank you.
Thank you very much, Madam Chair. And I'm honored to be here at ICASA 2025. Happy right here in my hometown, my country land. Welcome to Ghana. All right. So as she says, I'm a pediatrician at Kolebu Teaching Hospital, and I'm also a senior lecturer with the University of Ghana Medical School. I've been running our HIV clinic since about 2013, and I'm happy to discuss a very important topic which is close to my heart. That is, how are we helping children with HIV cross the bridge? That bridge over there, from childhood to adulthood. So let's start with some numbers. Globally, we have 2.4 million children and adolescents with HIV, and 90% of them are right here in sub-Saharan Africa. These are our children, our neighbors' children, our community's children. But the good news is that thanks to antiretroviral therapy, these children are now surviving to adulthood. That's wonderful progress. But it has created a critical challenge. The transition from pediatric to adult care has become the highest risk period in these young people's HIV journey. We see treatment interruption, virological failure, and tragically, loss to follow up. So the question is, how do we prevent this? Think of transition as a bridge. On one side, we have pediatric care, where children are born with HIV, they're with their caregivers, they're very comfortable. And on the other side, the adult care, where they advocate for themselves, they manage their medications and navigate a whole new system. This is a period where the children drop out of care. They stop taking their medications, and years of successful treatment just fizzles out. It's a big tragedy. But the gap is bridged by transition of care. So what is transition of care? So this is a purposeful, planned preparation for moving adolescents from child-oriented to adult care. It is a period where there's medically and developmentally appropriate care. It's not just a physical change of care from pediatric to adult providers. We're not saying just go here, cross the bridge, other side of the hospital. No, it is purposeful, planned preparation. So what makes this bridge strong? What holds it together? The answer is disclosure. The foundation of this bridge is disclosure. The WHO defines disclosure beautifully. Now, this was updated this year, July 2025. I'm just going to highlight the keywords. It is a process, not a one-time event. It's a process where the children and adolescents are made aware of their HIV status. It's not just telling them, it's empowering them to be able to safely and when ready disclose their own status to those who are important. It is empowering them to be engaged in their own health decisions. That is what disclosure is. Think about it. How can we expect young people to successfully manage their HIV if they didn't know that they even have it? So disclosure isn't just one conversation. It's a journey up a staircase with 5 distinct stages, each building on the previous one. So we start with before 7, that is pre-disclosure, where we're building trust with the caregiver and with the child. Then comes the foundation stage, about 7 to 9, where there's a simple message. You must take medicine daily to stay healthy. It's a very simple message. Then partial disclosure, about 9 to 11. We add a bit more detail, like your immune system needs some help. Then full disclosure, around about 11 upwards, direct and clear. You have HIV, and here's what it means. And then finally, post-disclosure, around 11 to 24 and beyond, where we have ongoing supports, counseling, and peer groups. Now, take note, every stage builds on the one before. Someone who is 7 to 11 may not even be ready to go to the next stage. It all depends on how inquisitive the child is, whether the caregiver thinks that the child is actually ready. It's not cast in stone. We do it according to the child's intellect and whether the caregiver thinks that the child is mentally ready for this. Each stage building on the one before. So there's no rushing. There's no skipping steps. You don't start from the top and just disclose. It should be based on a foundation. Just steady, loving progress. Now let me tell you why this matters so much. When we disclose, we see 5 critical benefits. We empower the child to take ownership of their health. There's better adherence and virological suppression. Understanding drives consistency. You'll be surprised. Once a child understands that I must take this medication so that I'll be healthy, you'll see that they'll agree with you. If they don't understand, adolescence is already a very trying period, so you need to work with them with understanding. Knowledge. They know their diagnosis, their treatment, and how to manage their condition. And finally, informed relationship decisions. They can protect their partners, their families. And the most important, their psychological health. Disclosure, when done right, actually reduces depression. And I will show you the evidence soon. Knowledge isn't a burden. Knowledge is power. Now, there are some caregiver fears. Despite the evidence, we still face barriers. What are the biggest fears? What are caregivers saying? My child will become depressed. They will tell others and face stigma. They are too young to understand. These fears are real. They are real. They come from wanting to protect the child. But here's the question. Are these fears justified? Are these fears really justified? in this day and age with AI. The children already know before you even tell them. You'd be surprised at what the children are reading right now and learning by themselves. Wouldn't it be lovely to have it in a protective environment, ensuring they get the right information? Let's look at what the evidence tells us. So this is a Sankofa study. Evidence from Ghana was based here. Now, Sankofa 1 was a study done, and Sankofa in Akan means go back and get it. Learning from past to build a better future. So we developed a structured disclosure intervention with trained specialists and adherents. It was culturally sensitive. We addressed Ghanaian specific beliefs and stigma, and we integrated it into routine care to make it sustainable. We didn't disrupt the routine care, we just integrated it. So we had a control arm and an intervention arm. The control arm was in my clinic, Kolebu Teaching Hospital, and the intervention was at Konfanochi Teaching Hospital. So we enrolled HIV children aged 7 to 18 years who did not know their status, and we followed them up based on, but the key thing for entry is that they did not know their status. So we started foundation, we built on until the children were ready to be disclosed. So, after a couple of years, but this picture here shows one of our review meetings. You can see me in red on the far right there. That was one of our review meetings in Accra 2023. So these are two of our publications. We published in 2015 and 2020, and we looked at HIV knowledge, stigma, and illness beliefs among pediatric caregivers in Ghana who have not disclosed to their children. And this was another one published in BMC. The Sankofa Pediatric HIV Disclosure Intervention did not worsen depression scores in children living with HIV in Ghana. So let's look at the findings in detail. So we found out that children under 11 years were actually 6 times more likely to be disclosed successfully than older children. So younger is actually better. The evidence is there, 6 times. What about depression? We used the Child Depression Inventory, CDI, and the Becker Depression Inventory, BDI. And what did we find? We found that the depression outcome, the scores actually decreased. The depression scores decreased after disclosure in children by 1.82 points and in the caregivers by 2.65 points, both highly significant. And we followed these dyads for over 5 years. Remember, we integrated, we followed them, addressing their concerns for over 5 years. That is what we did. Now, I won't pretend that everything is easy. There are real barriers at every level. So let's look at the level, the child caregiver healthcare. What are the barriers at the child level? There's fear, indeed, stigma, low health literacy. But then what was our solution? The solutions from our Sankofa study. We did a gradual age-appropriate education. So that is what it is, a gradual age-appropriate. So these were trained specialists. So it means you have to be trained. You have to have some knowledge in how to give appropriate message to the appropriate age. What was a problem for the caregivers? A fear of depression, lack of skills, stigma. As I said, trained counselors. We address stigma, and if you look carefully, this stigma was perceived stigma, internal stigma. They were stigmatizing themselves. They just needed someone to talk to them. We've had so many lectures and education on stigma for healthcare work, because at least in Ghana, stigma is not a big problem because healthcare workers have been educated not to stigmatize, but they have their own perceived internal stigma. Then lastly, the healthcare. The abrupt transfers, transition programs are inadequate. Sometimes it's a different caregiver. Every time the child goes, it's a different caregiver. The children feel loved and cared for when they see a common face, when they can identify. But if they come every day and there's a different face, then it's difficult to build trust. So as I said, we had specialized caregivers who they were there mainly for the study, and we followed them up, and we had structured protocols. So for every barrier, there is a solution. We just need the willpower to implement it. So how do we assess readiness to the final stage, that is transition to the adult stage? We assess three main key domains. So for medical knowledge, do they understand HIV? So this is from the last stage, before they move to complete independence. Do they understand HIV and their medication, their medical knowledge? Self-management, can they take their medications independently without the caregiver? Then finally, psychosocial readiness. Have they accepted the diagnosis? Have they been connected to support? Are there peer groups are there people they can talk to? This isn't just about age, it's about the readiness of the child. So we assess these three main things before we transition finally to the adult clinic. So let me leave you with 5 key messages. 1, disclosure is foundational for transition. Without it, everything falls apart. 2, early disclosure between about 7 and 11 years optimizes outcome. Don't wait. Step by step by step by step. Build on, just as you go onto a staircase. You don't jump straight. You take your time, slow progress. 3, the Sankofa evidence debunks those common caregiver fears. 4, a structured approach works. It should be structured. Then finally, the time to act is now. There's a need to scale up structured disclosure and transition readiness programs across sub-Saharan Africa. Now, I started by talking about a bridge, and I'll end with a bridge. Every child living with HIV deserves to cross that bridge safely from childhood to adulthood. They deserve the best of us, and we have the evidence, we have the tools. What we need now is the commitments from clinicians, from policymakers, from the community to make this happen. Together, all of us here, we can build bridges that hold strong. Thank you very much.
Our presenter, you'd like to sit down and we'll take this further. Once again, let's show appreciation to that brilliant speaker. We're going to open up the space to questions, and we look forward to you who might have questions. I see number 1, hold it there, number 1, number 2, number 3, gentleman at the back, number 3, number 4, madam, and number 5. We'll take those questions from you, and then how do you want us to, would you like to respond one by one to each question, or do you want me to pull it? So, all right, excellent. So our volunteers, please, I'd like you to go around. We have 5 persons. Have you helped me identify? You were number 1. I gave you number 1. No, I didn't. Please, there's a number 1. That's number 1. Thank you. Take your number, madam. That would likely be number 6. Okay, thank you.
Thank you so much. Good morning, ladies and gentlemen. My name is Noma Gugu. I come from South Africa, a region called KwaZulu-Natal. We appreciate very much the presentation that we have received because it's one of the challenges that we are faced with in the province, and how, our loss to follow up is mostly children who have had to transition but could not transition, mostly because they didn't get the information. And understanding what you've presented, we appreciate that, and I think we will take it up with us. But my question that I want to pose to you is, how do we empower parents to feel that they could be able to actually follow those steps to disclose? Because I think the biggest problem is the fear that the parents more than the children. Because once you give the children information, like you were saying correctly so, children are very quick to pick up, and if you give them information in a proper manner, they absorb it like a sponge. But the problem is the parents who don't feel empowered enough to provide. So how do you propose or you suggest we work on that? Because I think if we do that, then we would have been 50% or even 60% down the road.
Excellent question, thank you. Number two? Who's on number two? Were you number two? Okay, good. Thank you. And then number three is where? Yes, number three, thank you.
Right, thank you. My name is Gifty Brago from Ghana. Thank you so much, Dr. Afrani. My question is sort of an add-up to the first question. It's also a great concern regarding parents who feel less powerful, they feel less empowered. How do you deal with mothers or caregivers who insist that disclosure should not be done when you could really tell that disclosing to the child would really make a lot of difference, but they keep insisting that it should not be done?
Great question, and great ethics question. Yeah.
Thank you very much for that well-put presentation. If I was to go back to medical school, I would probably want to be in your lecture hall. Very well delivered. My name, Dr. James Amenge from Kenya. A few clarifications I would want to seek. So one, in the experience that you had, is there a difference between children who are being taken care of by their biological parents in terms of the disclosure process, acceptance to disclose, the support required, vis-a-vis those who are being taken care of by other caregivers, including the elderly caregivers? Our society has, unfortunately, some of the parents having left their children behind due to the scourge of the HIV, and they're left behind with their grandparents. Is how are we handling that gap or that difference?
Excellent. Excellent.
And then finally, if you allow...
No, I won't. Apologies.
Thank you very much. That's enough.
Don't worry. Maybe in the second round you can come. Let me take the first round of 5. Yes, please. Papa, volunteer. She's here. Number 4 is here. Thank you. Just hold it. We'll have a second round. That might come up.
Thank you so much for the presentation. I'm Rose from South Africa. So I'm building on what Norma is asking. We're implementing a community project and for impact for HIV, 0 to 15 years. And we've seen that disclosure is one of the biggest challenges that we're facing in South Africa, despite the fact that we've got guidelines outlining the process. Like you said, it's not an event. However, the challenge is that because facilities are so busy, it's hectic, these processes are not followed. So we've seen that there's accidental transition. Actually, children are just transitioning to adulthood. There's no defined systems and processes that are currently implemented. And from your study, what can be done differently, because it's a serious challenge. But also, secondly, we're picking up that mental health is a big issue in HIV and AIDS and disclosure in children. And it's actually the biggest contributor in terms of loss to follow-up and, falling out of treatment. So what can you recommend that we do differently? Thanks.
Thank you. And number 5. Number 5. Excellent.
Thank you so much. My name is Nobutula. I am from Zoe Life in South Africa. I actually don't have a question. I do have a comment just to say, looking at what you were presenting in terms of the younger you involve the children, it's better for disclosure. And also just to add as well that we've also seen that when you enroll them in a support group at a younger age, while they're still on a partial disclosure, it actually puts less pressure on a caregiver, because while they both, we actually enroll them both in a support group and then they go through the same education. So we've seen that if they enroll at a younger age and the caregiver is being educated, it actually gives us the best outcome. Thank you.
Excellent. Thanks for sharing that. Before you not fully answer the question, I'll just add 1 or 2 layers so that you take, based on the things I've heard, where parents may be hindrances for that disclosure, whereas there's global evidence that disclosure may otherwise be different. Is there a place for healthcare givers or the social workers or the clinical setup to recognize that children are the properties of the state? And therefore, a parent standing it as an hindrance to get the best for the child becomes a legal entity that you can actually sue for disrupting the process. Do you think there is a place for that? Just asking. Don't worry, I'm all theories. And then, please, what does it mean for children in boarding schools? I think boarding school completely disrupts the beauty and the brilliance of this program. What's been your experience for those in boarding schools? Thank you. And then you take that, and once we have time, room coordinator, please let us know how well we're doing with time. Then we take the second round of questions. Over to you, madam.
Thank you very much. Very important and stimulating questions. So I'll start one by one. So the first question was how to empower the parents. The question was the children themselves is not an issue, but the parents themselves do not feel empowered, and that is very true. So that is why it's important to do it stage by stage. Remember, I mentioned that the pre-foundation was about building trust with the caregiver. It's just about trust. It's just about them being able to talk in confidence with the caregiver. Now, with a Sankofa study, we saw the patients, we call them dyads, both the child and the caregiver, throughout every single time they came. I mean, in real life, as you said, it's a very busy world out there. And this was a study, this was a clinical trial. So I must, as I said, in the real life, it doesn't exist or so. So you need to try and see how best. So what we did was that they were trained psychologists, and ideally there should be a psychologist in every HIV clinic, attached to an HIV clinic. Ideally, yes. And I know that that ideal situation is not there. There's a physician assistant who acts as a nurse, who acts as a doctor, who acts as everything. Really, I am from a tertiary hospital where things supposedly work, but I must say that in your village out there, it may be difficult to do exactly what we did, but then you can adapt. You may have to look at your situation. I'm answering two questions at a time. You may have to look, I'm answering your question too. If it's a very busy clinic, how best can you do it? What you can do is that There are some clinics that they run the adults and children, everything together. But you may decide that in this particular month or so, you're just seeing children. So what we do, so our HIV clinic sees to about 14, 15, then we transfer, we have an adolescent HIV clinic. Before the adult clinic, we are lucky, we have 3 stages. I'm answering a lot of questions at the same time. So what happens is that when they're before we transfer them, they must have had disclosure. And we try and talk to the caregiver. So you see in our notes, prepare for transfer, prepare for transfer. So transfer is just not once. As we are talking, as we get the feeling that the child is growing or so, we start the preparation. So you see another, in the notes of the doctors, prepare for transfer. So we keep impressing on the caregiver that there is the need to transfer. So that is what it is. It's a gentle nudge. It's a stepwise. You keep on telling them there is a need. And a lot of people don't want, they say the child is not ready. But we keep on insisting, we keep on, and at a certain time, especially when they're above 15, we tell them that we're going to just sack them and go. We literally joke with them. But mind you, we do have children who are developmentally delayed. 16, 17, they're still with us. And because they're developmentally delayed, they are small. So we kind of still keep them in the clinic. You know, there are exceptions to those ones. The caregivers are actually fear how they're going to manage. But we keep them as long as possible because really in their mind, they're still pediatric minds. Yes, so I've answered 3 of the questions with one statement: how to empower, what we do with the busy clinic, and then how to ensure that the caregiver, if he keeps on insisting, so it's a gentle process. There's a question about a difference with the biological parents and other caregivers, including the elderly ones. So from my experience, sometimes the elderly ones are the most knowledgeable ones. They can actually take very good care. I mean, that's what they do. That's their pension. They bring the child every day. They know the medications. It's in their bag. They can give out to you. Whereby the biological caregiver is so busy. Sometimes when the grandmother comes, we speak to the biological caregiver on the phone. The biological caregiver is so busy doing so many things. So sometimes the other caregivers are actually better, especially the elderly. I'm glad you clarified the elderly, because some come with their sisters. You know, some actually come with other caregivers who really don't know much. They don't know when the last visit was, and it can be very difficult. We have to call a number on phone to get the information, because some people, it could even be a neighbor, they just want someone to accompany the child, which isn't the best. We want continuity. So when this happens, we take the phone and call the caregiver. If there's no continuity, we can't build on that staircase. The problem is, one day this caregiver comes who doesn't have a clue of what is happening. Then the next day, another caregiver, that breaks, and the child is confused, because we always talk to the caregiver before talking to the child. Especially if the child does not know the diagnosis. We don't talk at the same time. The child will wait outside the consulting room where we have the first conversation. And one of the conversations is, has a child been disclosed to? Because you can't be talking openly, anyhow, mentioning HIV in front of a child who has not been disclosed. It's not right. It's not right. Some of us make that mistake. The children are very intelligent. Whilst they're even in the waiting, they hear kind of things, and you'll be surprised. They know, even before we disclose, and the caregiver will be like, wow, and I say, it's true. They're discussing it in school, and they get to know. They read. Once they can read, they see things. They see the bottle. They go on Google, and they know. So mental health clinics are busy. Place for caregivers to recognize. So the last question was on the ethics legal question. So as pediatricians, when a child needs blood transfusion, we're able to get a court order and transfuse, because the child is for the state. There are legal conditions. I haven't had a case where we've had to override, refuse, or a parent has refused to disclose, because it's a gentle process. And it is a chronic something. Blood is life-saving. If a child needs blood instantly, you have to give it there and then. But disclosure is a process. So if today the parent didn't agree, next time is there. You try. You keep on trying. It's a process. It's a staircase, little by little, poco a poco. Thank you.
Thank you very much, really great. We have 5 more minutes and we'll take questions. Someone is holding a question somewhere in the left hand. Is it still there or it's been answered? No, there was someone at the back that wanted to ask too, I know. It's answered, excellent, thanks. So your question is going to be 30 seconds. No thank you, nothing, just go to the question, that's number 1. Number 2, madam, number 3, and number 4. Please, I plead, I'm very serious. No, thank you. Once you say thank you, that's your question. All right, so.
How do we bridge the gap between the institutions where these kids actually go? Because we're thinking of the hospital or the health institutions, but they have the churches, the schools, the play spaces. How do we bridge that gap?
Very good. Great. Number 2?
Yeah, mine is not a question, just to add that it's a brilliant presentation. And for us from Nigeria, we just had a guideline and a job aid signed on disclosure. So understanding the fact that caregivers or parents are barriers, so the process of disclosure goes hand in hand. The caregivers, the healthcare providers are trained, and the disclosure process happens with the children and the caregiver.
Thank you. Do you have it at your booth? Do you have those guidelines at the Nigerian booth?
It's still in the no, it has been signed. It's there.
Is it in the booth?
I don't know if it's there.
All
but
right.
we have
I wanted to ask people to go there. Is it online? You don't know.
It should be on NASCAP website.
All right.
Thank
So
you.
please check the booth, Nigerian booth. Please check the NASCAP website if you want access to the guideline. Thanks for sharing that information with us. Last person. Thank you.
Disclosure really is an issue which we'll continue to battle with. If you all remember, ever since we started talking about HIV, disclosure has been a problem. And I was wondering, or maybe just to challenge the room to say, when you talk about it as a process, are we also not giving parents, caregivers a leeway to delay the process? Because it then, I will go on with the process and on and on. And also to add on that, peer providers are also a key component who can support with disclosure as they spend most of the time with their peers. Thank you.
Excellent. Over to you, madam.
Thank you very much. So, bridging the gap in other...
Okay, apologies, Alan, there's one we're leaving behind. We don't want to leave behind.
And the first and the last week shall be the first. Okay, thank you. One, I was asking.
Not 2. We only have 30.
I was asking how best can we lessen the number of items that these children are crossing in this particular bridge. If we notice, they are at that age of theirs, they've got the growth issues. They are facing the social issues. They are facing, it's a lot. And this is the very time we are also bombarding them with the truth about their health.
Okay then, thank you. All right, go ahead.
Thank you very much. I'll start with the last. The adolescents, and I'm also going back to the question about boarding school. So what do you do? So we actually put them together. Maybe this month is just for the adolescents, maybe when you're on their vacation. We come together, we talk about puberty, we talk about so many other issues. As I said, they are fundamental things that the adolescents and they have challenges. So we take our time to talk to them and educate them on issues concerning adolescents. So it's a peer group. They get to sit in a circle and there are doctors in between and we get to talk with them. Now, bridging the gap in other institutions, in churches and likewise. So when I'm teaching my medical students, I tell them that HIV right now is a chronic manageable disease, just like hypertension, just like diabetes. Once you are suppressed, Yeah, there's nothing, in fact, you could be very stable, you just come for your medications, you are very fine also. So there's nothing, there's no stigma, it's not a big deal to have HIV right now. So that's the message. It's a manageable chronic illness. Once you take your medication, now we're going to be having even injectables very soon. You are perfectly well. There's no big, what's the problem with HIV? Is it written on your face? You can't tell. There's nothing wrong with having HIV once you take your medication. And these are children who are born with it. Let's not forget, it's not their faults. We're not talking about blood. Some had it through blood transfusion, yes, but these are people who sometimes they can get confused. Why me? Why me? That is very challenging. You just come, but who asks for it? But there's always a silver lining around every cloud. So let's make their lives better for them. All of us, it's going to take all of us to do that. Thank you.
Thank you very much. Thank you very much. Let's show appreciation to our interpreter. We acknowledge the role you've played. I think for us as to note, I would say everything is perfect, but that there is much to invest in that transition. It's not just the clinic, but there's a whole world around the clinic. It's also noting that the future of people with HIV and aging, the increased risk of non-communicable diseases with people living with HIV, and these are realities of their lives that we have to manage. The whole, I think the beginning and end is that we have to invest in improving the quality of lives of young children that they might live to their fullest. On that note, I want to thank every single one of you. You've been brilliant. I want to show my appreciation to you. Let's give a round of applause. Have a wonderful day. Please hold those flags. I've looked for sorry.